I would like to invite our chairperson to kindly present a token of memento to Dr. Brij Mohan Makkar.
Good evening, everyone. Thank you, Chairpersons. At the outset, I must thank my dear friend Jyoti for this great opportunity and also thank USV for, involving me in this session. As you know, I'm going to speak on fast-tracking heart failure from timely diagnosis to guideline-directed medical therapy with SGLT2s and ARNI. And my disclosure is that this is a USV presentation, and I am on their speaker panel as well as their advisory board. So we know that burden of heart failure is increasing globally, and India is not behind. We have 1% of adult population with some degree of heart failure, and the incidence rate is also about 0.5 to 1.7%. That means every year we are getting anything between 5.5 to 1.5 million people added with heart failure. Now, another important thing we have to keep in mind is that heart failure in most of the patients can be mild. And that time it is not causing much problem. It doesn't come, as a problem which you suddenly diagnose and it is there. And it may be there for quite some time till it becomes worse suddenly, and then you realize that you had a problem which was actually very serious. So this is a quote that heart failure rarely knocks loudly. It keeps whispering until it shouts and you start listening to it. Now, going about diagnosis of heart failure, the most important thing is you have to suspect and you have to screen with NT-proBNP. And there are clear-cut recommendations from ACC, AHA, and Heart Failure Association guidelines for screening for heart failure. There are class 1 recommendations for using NT-proBNP in people with dyspnea to make a diagnosis of heart failure or to exclude the diagnosis of heart failure. In people who are hospitalized for heart failure to make a prognosis, how well they are going to do and what is the prognosis. And in people with chronic heart failure, it is important to keep doing serial NT-proBNP to make sure that risk stratification is clear and you have to act accordingly. In addition, there are class 2A recommendations for using NT-proBNP in people with hospitalization for heart failure. Especially a pre-discharge NT-proBNP can be useful to inform the trajectory of the patient and establish a post-discharge prognosis. And also in patients who are at risk of heart failure. It can be very useful to develop a team-based approach when to involve a heart failure specialist and what kind of LV dysfunction we are going to look at. Now, conventionally, we have been, using a very slow approach in management of heart failure. And there was, you start with one drug and slowly up-titrate and go on to second drug. But things are changing. We are moving to fast-track model with the strategic sprinting, as it is called, during the vulnerable phase. So it is early and rapid titration of simultaneous drugs, which are the core pillars for management of heart failure. And we know now that first 90 days post-discharge are very crucial. They are the golden window. And the goal is to reduce readmissions, mortality, and optimize outcomes and improve the quality of life. Now, as I mentioned, there are 4 pillars of heart failure treatment. The 4 key molecules, which are SGLT2 inhibitors, ARNI, beta blockers, and MRAs. And of course, those people who have, fluid overload, diuretics, remain a important part or integral part of therapy. Now, with the introduction of SGLT2 inhibitors, there is a revolution in management of heart failure with preserved ejection fraction, which we always thought it's a mild thing. And of course, with ARNI, we saw a paradigm shift in the management of heart failure with reduced ejection fraction. Now, this slide shows you, all the major cardiovascular outcomes with SGLT2 inhibitors. The top 3, DECLARE, EMPA-REG, and CANVAS, are the CV outcome trials, and CREDENCE was basically for the renal outcomes. Now, all these trials, which included almost 40,000 patients assessed for cardiovascular safety as well as renal safety, showed that at end of almost 3 years follow-up, there was significant 30 to 40% reduction in the hospitalization due to heart failure, which we were not looking at as a, for primary outcome. The primary outcome was the cardiovascular outcomes. And this was very, very significant. And if you look at these trials, the patient population with pre-existing heart failure was anything around 10 to 12%. But the benefit you saw was 30 to 35% reduction in the hospitalization due to heart failure. So it clearly showed that SGLT2 inhibitors play an important role in prevention of heart failure hospitalizations. Now, how do they do it? The SGLT2 inhibitors reduce the preload and afterload, both by reducing plasma volume and vascular resistance. They improve myocardial fuel energetics, shifting the metabolism from glucocentric and lipocentric to ketocentric. So ketone bodies are utilized as a fuel, which improves myocardial efficiency, and they also reduce cardiac remodeling by reducing the inflammation or fibrosis and the cardiac wall stress. They also have reduction, they also lead to reduction in blood pressure to the tune of 3 by 5 millimeters. They also improve cardiac contractility by reducing the LV mass and improving diastolic dysfunction, thereby leading to protection against myocardial injury and heart failure, and leading to improved outcomes and reduction in the heart failure hospitalizations. Now, I'm sure you already have seen these studies. This is the, onto your left, you have the heart failure the Emperor study, which was done with empagliflozin in people with heart failure with preserved ejection fraction. That means the EF ejection fraction was more than 40. And all these people were randomized to placebo versus empagliflozin, added to standard of care, followed up for almost 3 years. At the end of 3 years, there was significant 21% reduction in the risk of hospitalization due to heart failure or cardiovascular death, composite. So 21% reduction. Onto your right, you see the DELIVER trial. Again, similar protocol. Patients were people with heart failure with preserved ejection fraction, treated with dapagliflozin versus placebo added to standard of care. 3 years down the line, you see 18% reduction, which is statistically significant. So both trials show that SGLT2 inhibitors play an important role in reducing the hospitalization due to heart failure and cardiovascular death in people with preserved ejection fraction. Now, this is a data analysis of combined data set of Emperor preserved and Emperor reduced trials. So similar to Emperor preserved trial, the Emperor reduced was done in people with reduced heart failure, ejection fraction, which means they had ejection fraction less than 40. And they compared the benefits in the different groups of ejection fraction. That means they compared those with less than 40% to 40 to 50%, which is now labeled as heart failure with mildly reduced ejection fraction, and those with more than 50%. And it showed clearly that there was significant benefits. Let me use a pointer here. So you will see this red dot on screen now. So if you see there is a significant 25% reduction in CV death or heart failure hospitalization in people who had EF ejection fraction less than 40%, almost 30% reduction in those with 41 to 50%, and another 17% reduction in people who had EF more than 50%. But important thing is, if you look at the confidence intervals, all three were statistically significant. And they showed superiority of usage of SGLT2 inhibitors in this population. Now, let me change gears and take you to the studies with ARNI. Now, I am sure you have been, part of some ARNI presentations and you know this data. But the most important study was Paradigm Heart Failure Study, which showed 20% reduction in primary endpoint of death and from any cardiovascular cause, and 21% reduction in hospitalization due to heart failure in people who were randomized to ARNI versus enalapril, added to standard of care, and these people were having heart failure with reduced ejection fraction. And this was the major study which led to the approval of ARNI for management of heart failure. Then we have PROVE heart failure study and the PIONEER heart failure study, which both showed benefits in terms of improving ejection fraction and reducing the anti-pro-BNP levels significantly, and improvement in LVEF in people who were treated with ARNI. This was a study which looked at the effect of ARNI, which is sacubitril/valsartan combination, versus valsartan alone in people who had de novo heart failure or acute versus chronic heart failure with preserved ejection fraction or mildly reduced ejection fraction. And after use of this combination, there was reduction in the anti-pro-BNP levels, but the difference in two arms was not statistically significant. So there was benefit, but it was not statistically significant. Then sacubitril/valsartan combination was also used in patients who were hospitalized with decompensated heart failure. This is the pooled individual patient level analysis from 2 randomized trials involving more than 1,300 patients with reduced, mildly reduced or preserved ejection fraction. 89% were hospitalized plus 11% were emergency care. The results showed that anti-pro-BNP got reduced by 24% with combination of sacubitril/valsartan, and the reduction in CV death or hospitalization due to heart failure was 30%. And the benefits of the combination in patients with EF less than 60% were there, but not there in those who had EF more than 60%. So, based on these, how the guidelines have evolved. There is class 1 recommendation for SGLT2 inhibitors to be used in patients who have mildly reduced ejection fraction to reduce the risk of heart failure, hospitalization or CV death. There again class 1 recommendation for SGLT2 inhibitors in patients with preserved ejection fraction to reduce the risk of hospitalization or cardiovascular death. There again class 1 recommendation for SGLT2 inhibitors to be given in patients with type 2 diabetes and CKD to reduce the risk of heart failure, hospitalization and CV death. So in nutshell, SGLT2 inhibitors are recommended for treatment of patients with preserved ejection fraction, mildly reduced ejection fraction, as well as reduced ejection fraction, or people who have CKD to reduce the hospitalization risk as well as cardiovascular death. Now, how do we initiate guideline-directed treatment therapy? In people who have reduced ejection fraction, you start with all 4 drugs. That means ARNI, which is sacubitril/valsartan combination, beta blockers, MRAs, and SGLT2. If the EF is more than 50%, SGLT2 inhibitors with symptomatic relief, but you have to focus on patient education and the multidisciplinary involvement, and in case you need, you refer to heart clinic, heart failure clinic or so. Now, if you go by serial strategy, you start with 1 drug, add 2nd drug, add 3rd drug. It may take anything between 24 weeks to 1 year to get to the full intensity of therapy. And now it is recommended that you have to act fast, and we know from studies that the benefit starts coming as early as 12 days in people who were treated with empagliflozin, reduced study, and if you look at the PIONEER HF, the benefit came as early as 29 days in people who were treated with sacubitril/valsartan combination. So you have to start early with full doses, and if you look at the data, this was a study where in one group they had rapid intensification of therapy with multiple drugs, and other was usual care group, and in 6 months' time, there was significant reduction in the heart failure, hospitalization, as well as CV death in people who were treated with the intensive therapy. So you have all kinds of recommendations, but the current recommendation is that you start with all 4 drugs simultaneously, rapidly up titrate and try to achieve the maximal tolerated dose within 4 to 6 weeks, at best 3 months. Now, for this, we need awareness. There are other challenges, barriers to implementation of guideline-directed medical therapy, and one of them is the accessibility, affordability, and availability. Accessibility is better in India now. Affordability has become better with the, off patent these molecules going off patent, and of course, the patient's, awareness is also very important. Now, once we have these molecules going off patent, the cost has come down significantly by almost 85%, and this reduction in cost actually enables patient to use more of these therapies and cut down the risk both of mortality as well as hospitalization. So it is very important to have early diagnosis and fast track guideline-directed medical therapy for all patients with heart failure, because this helps in reducing the outcomes and improving the quality of life. Thank you. With that, I would also like you to block 2 important dates. We are going to have ACCD program on 31st August in Delhi, and we also have the Asia Oceania Congress of Obesity coming up in Delhi on 19 to 21st of December. This is the old date. The date is now 19 to 21st of December. Thank you so much.
Okay, thank you, sir, for the excellent presentation.